So I am going to talk to you about some preliminary results. I know there's a lot of people here that are interested in this, of a project that we did to assess prevalence of per and polyfluoroalkyl substances, or PFAS, within the blood of individuals throughout Maryland. This is a project in combination between the Maryland Pesticide Education Network and Johns Hopkins University, with very generous funding from the Jacob and Hilda Blaustein Foundation. Next. So I want to start with my acknowledgements up front. First, I really do want to acknowledge this would not have been possible without the research team that did a fantastic job. I was just, sort of like, I'm going to present some of the results, but they did the heavy lifting. So Caitlin Series is a project co-principal investigator. She's assistant professor in the Department of Health Sciences at Towson University. Mr. Sean Lynch is the project director and integrated pest management in healthcare facility project for MPM. Dr. Diana Egnor, she did most of the data analysis for this study and plotted all of the figures that I'm going to show that have graphs. She plotted them. Mr. Jack Solomon is a GIS expert, and he did all of the maps that I am going to present. And doctors Michael Ichniowski and Vicky Blazer are project advisors, and these would not have happened without their vast expertise on PFAS, and both in human and the environment. Next. So briefly, I'm going to tell you what PFAS are, sources, what we know about levels in the blood in the US population, and some of the health risks that we know. The goals of our study, the methods that we used, and I'm going to try to get as soon as possible to the results, and a brief discussion and next steps. Next. So as we have been hearing, PFAS are known as forever chemicals because they really resist degradation and breakdown in the environment and in our bodies. They are found in many of the consumer and industrial products that we use, including, among others, very, very common is nonstick cookware, water and stain repellent fabrics, and some foam for firefighting, but interesting for this group of people is some pesticides, as Dr. Blazer just explained. Next. So since 1999, the CDC, through the National Health and Nutrition Examination Survey that you may have heard happens every 2 years, has been measuring PFAS in the blood of the US population. So we have here a graph of the last, since they have started measuring PFAS since 1999, all the way to 2018. One important point to make is that about 97% of the US population that have been tested, which is representative of everybody, have PFAS in their blood. Due to some health concerns with a few PFAS and PFOS and PFOA in particular, they have stopped manufacturing them and substituting with other PFAS, which is how we can attribute this decline in some of the PFAS. But I just want to caution that this is a national average that hides a very wide variability. This is not representative of everybody everywhere. And they only tested a few selected PFAS. So in our study, we expanded to test a few more and to focus in Maryland. Next. So even though we're still studying PFAS and the health effects, and we don't have a full understanding of what exactly they do to our bodies, there is sufficient evidence of an increased risk of cancer, especially kidney and testicular, weakened immune responses, elevated cholesterol, liver damage, and decreased birth weight. And this is especially important. We have to keep in mind always the vulnerable populations, like the pregnant women, children, immunocompromised people, and people in environmental justice communities, which are impacted by many other sources. Next. So the National Academies of Sciences and Engineering and Medicine in the last couple of years came up with a group and made recommendations for clinicians on what to do. We are beginning to be able to test these PFAS in the blood of people, but we don't know what they mean. So based on the sum of PFAS, which we're going to call the NASM or NASM PFAS in the blood, they came up with these 3 tiers. So if you have less than 2 nanograms per milliliter in the blood, your physician is not going to recommend anything different than what's typically done. Between 2 and 20 nanograms per milliliter, the clinician is going to encourage exposure reduction, see where you can find some sources that you can reduce, and screening for high blood pressure, hypertension, and breast cancer. And above 20 nanograms per milliliter or higher, then some additional tests would be required, including some thyroid function testing, assessment of kidney cancer, testicular cancer, and colitis. Next. So the goals of this study, as I mentioned briefly, are to characterize the concentrations of 45 PFAS chemicals in the blood of a sample of residents in Maryland. The second goal is to evaluate factors that potentially contribute to these exposures. So we asked participants about proximity to PFAS contaminated drinking water, some lifestyle recreational exposures, dietary preferences, and occupational exposures. And then we computed summary statistics for all of these to show you some of the data. Our hypothesis was that certain populations are disproportionately exposed to PFAS pollution across the state of Maryland. Next. So we recruited 42 participants from across Maryland. It was a convenient sample with a goal to recruit at least 5 per region. Participants answered a questionnaire through Qualtrics, so that we can get information about their age, gender, race, where they live, and some behaviors that expose to PFAS. Then Eurofins, working with Eurofins, which is a commercial lab that tests for PFAS, they sent each participant a kit to self-administer a finger prick test. Participants sent their blood sample back to the Eurofins, and they measured the 45 PFAS. Each participant received the results back within 2 weeks, and then we are receiving all of the results so that we can compute make the statistics. And then our team analyzed all data to assess associations between the PFAS in blood and socioeconomic and behavioral factors. So like using SAS statistical package to plot the PFAS and ArcGIS to map the geographic distributions. Next. So here goes the preliminary results. Next. These are the first 32 participants. We don't have the whole picture yet, but it's most of them. So the first way in which we thought to express this data, and there's many ways to look at it, but this is called a cumulative percent distribution function, which shows you each of these points is the value that was reported for each of for participants for the total PFAS, which is the value that is used for these breakdowns of thresholds in the blood. So we can see 2 of them, 2 participants had less than 2, which is that first vertical line, and then 20 micrograms per nanograms per milliliter is that other vertical line, and 3 participants are higher than that, had levels of PFAS higher than that in their blood. And the rest of the participants, 27 of them, fall between these 2 and 20. And so there's a huge range, as you can see. One thing that is interesting about this graph is that you can tell, for example, what is the median. If you look at that 50% in the middle, if you go down to the horizontal axis, you can see that 8 nanograms per milliliter was around where the half of the population of our sample is located. Next. So another way to look at that data is the same 32 participants is with these box and whisker plots that show you the distribution of the blood concentrations detected. And in this case, we plotted by gender. So we have on the horizontal, we have the different PFAS that had at least one person test positive for them. And on the vertical, we have the blood serum levels in nanograms per milliliter. So by by PFAS, we have these pairs of blue and red. The blue are the males, the red and the females. And I have added these red horizontal lines on the first two, which is for the ones that we have national averages. So the national average for PFOA, which is the first pair, is 1.4 nanograms per milliliter. And as you can visually see, there's really no difference between the middle of the boxes. The boxes are very overlapping. The only difference is that the females have slightly more wide distribution, but that doesn't mean anything really. But for the second one, for the total PFOS, you can see that most of the males fall above the average, the national average, and most of the females fall below. As Dr. Placer mentioned already, the total PFAS, which is this NASEM third pair, follow very closely the total PFOS or PFOS. The rest of the boxes we put here just for information, but there's no difference between males and females, and they are lower in general than the PFOA and PFOS. Next. Oh, okay, the colors are completely different here than what I was expecting. But here we have another way to look at that data. We have the age of the participants on the horizontal line. So our youngest participant was 29 years old, and our oldest participants were 75. In light gray, I hope you can see, are the males in our study, and in blue we have the females. The females actually, for this total PFOA, is the only one that had a correlation or association between age and concentration. So the older the females in our study, the higher they tended to have concentrations. But there was no correlation for males, and that correlation did not exist for any of the other PFAS that we looked at. Next. So then we plotted the PFAS serum concentrations by region of the participants where they lived. So we have here in the first set of boxes, we have total PFOA. In the second set, we have the PFOS, and then the NASEM total in the third blob set. And as we can see here, the only one that was slightly higher are the people in the southern region of Maryland. So just keep in mind, if you see these numbers in the middle of the graph, we have 10 people in the blue box, 13 people in the central region of Maryland, which is the red, 4 people in the eastern green, only 3 people in the southern region, and 2 people in the west. So we were trying to get a few more people from these regions to increase our numbers. Next. So look at that same information on a map. We see that the PFAS in serum by region and age ranges. The darker color is the age, and the bigger the dot is the higher concentration. So there's no really association. You can see where we have the participants, but we didn't see a big association between age and region. I mean, concentration and age, just the southern region. Next. Then PFAS by income ranges is the other way that we looked at it, at the data. And again, hopefully you can see just visually, there's no association. We did not see anything. There's no association. Another thing to keep in mind is we have only a few in the lower income ranges, so we also cannot say a lot more about this. But we have 7 people that in our sample that earn less than 75,000. Then in red, we have between 75,000 and 150,000, and in green, greater than 150,000, which is only 11 people. Next. And this is the same thing plotted in a map. So here, Jack plotted here the social vulnerability, which is an indication of how vulnerable you are to environmental impacts, social and environmental impacts. And in circles, in purple circles, we have the higher concentration, the darker the circle. And we really don't see any association. You don't see the darker circles where you have the darker areas. So by census tract. So no real association there. Next. So in conclusion, every one of the participants that we recruited had PFAS in their blood. The males in our study have slightly higher PFOS concentrations than females, and there were no difference really in the PFOAs. The age of females in our study has a weak positive correlation with higher PFOA concentrations. So the older people tend to have higher concentrations, but there were no other correlations with other PFAS. We also found the highest concentrations of PFOS in our participants from the southern region. And there were no difference really in PFAS concentrations either by income or by water supply, which we also plotted, and there was no correlation. So definitely more research is needed to confirm the differences that we see in this population. It's a small sample size. So next slide, we have a few of the strengths and limitations of our study. Some of the limitations are really that it's only 32 participants of the whole state of Maryland. So it's a very small sample size. It's not necessarily representative of the whole state. We don't have equal representation of all the regions, or equal representation of the ages, or equal representation across the income brackets. So we can see some trends, but we really cannot say anything else about that. But some of the strengths of our study is that it's one of the first studies to report 45 PFAS. In Maryland, some of the PFAS in pesticides cannot be measured in the blood. But it's a snapshot of Maryland areas of concern. So hopefully we can follow up on this. Thank you.